Good afternoon, dear colleagues, dear friends. It's my great pleasure to welcome you to today's webinar on the joint guideline of the European Stroke Organization and the European Association of Neurological Societies on the acute management of intracerebral hemorrhage. I'm speaking today on behalf of myself, Thorsten Steiner, and the two co-chairs of this guideline, Rustam Al-Shahi, representing ESO, and Andreas Rabe, representing the EANS. This collaboration reflects a truly interdisciplinary effort between vascular neurology and neurosurgery, which is essential for the care of patients with intracerebral hemorrhage. Next. The guideline was first presented during ESOC and digitally published on May 22nd, 2025, and subsequently published in print in December 2025 in the European Stroke Journal. Next. It is the work of 22 colleagues from 12 European countries. And allow me a few words on the methodology and the scope. Our recommendations were developed strictly according to the GREAT methodology. From the outset, we placed a strong emphasis on study quality, focusing primarily on randomized controlled trials and on outcomes reflecting true clinical benefit for patients rather than surrogate endpoints. In total, the guideline addresses 37 structured PICO questions, which form the scientific backbone of the document. These questions organized into 6 major thematic subsections, and these 6 subsections also form the structure of today's webinar. Accordingly, we will have 6 talks, each followed by a short Q&A session. Should time not allow for all questions to be addressed during these individual discussions, we will add an additional 10 to 15 minutes for questions and discussions at the end of the webinar. Our systematic literature search was extensive, identifying 115,647 articles. After rigorous screening, 208 randomized controlled trials were included in 74 meta-analyses we performed to inform the evidence synthesis. Based on this work, the guideline provides 37 evidence-based recommendations. Importantly, in areas where no randomized evidence was available, we developed 17 expert consensus statements using a structured Delphi voting process to ensure transparency and broad agreement. And with this, we hope the guideline provides not only recommendations, but also a clear framework for clinical decision-making and future research. And with that, I will now hand over to Rustam and Andreas to briefly introduce themselves.
Good to have everybody join us. I'm Rustam Al-Shahi Salman from Edinburgh. I was the vice chair. Over to Andreas.
Thank you. My name is Andreas Rabe. I'm the moderator. I'm the EANS representative. And Thorsten and I would just now hand over to the first session, right?
Yes, please.
So it's my pleasure to introduce you all for the first section about the general management. I would like to invite Diana Guiarte Sousa from the Medical Faculty of Lisbon to present.
Thank you very much. Good afternoon, everyone. So as mentioned, I will be briefly presenting on the general management of spontaneous ICH, which is this first section of the guideline. So let us start with a clinical case that illustrates some of these key management principles that we will discuss today. So we have a very typical case, a 52-year-old right-handed male presenting with acute left hemiparesis. His past history was significant for arterial hypertension, which is also very common. And also he had atrial fibrillation and ischemic heart disease, for which he was taking rivaroxaban 20 milligrams a day. And you see the image, so it is a deep large, deep heterogeneous hematoma with a little midline shift. And so let's move to this first section of the guideline. So it includes, as you see, 3 areas. So first, stroke unit care, management and specialized units. Second, the radiological investigation for etiology, which includes imaging scores and type of imaging. And third, the outcome prediction, including withdrawal of treatment. And due to time, we will mostly concentrate on these acute decisions, the management on specialized units, and withdrawal of treatment, restriction of care. So perhaps the most fundamental question, and indeed it is one of the very few strong recommendations we have, is this admission to an organized stroke unit compared with the general ward. And this first question, we have this strong recommendation based on moderate quality of evidence that these patients not requiring, of course, ICU treatment or neuro ICU, there's a recommendation for admission to organized stroke units to reduce death or dependence. And this is based, as you see in this landmark study, this systematic review and meta-analysis from Stroke 2013. It has an analysis on ICH studies specifically. And as you see, stroke unit care is associated with a reduction on the relative risk of death or dependency of 0.79. And it is indeed a very hard outcome, so death or dependency. So let's go back to our patient and indeed speaking of what the stroke units can do and management of complications, indeed this was again a typical case. We had a long admission for a complex patient, 3 weeks. During the admission, he had several complications. Hypertension was difficult to manage. He had hematoma expansion and neurological deterioration. He also had hyponatremia, a bit of hydrocephalus, delirium, and a recurrent stroke, so an ischemic stroke. And you remember this patient also had AF. However, despite all these complex treatment decisions, he was able to be discharged home, and at 6 months he had a ranking scale of 3. He was able to walk with assistance, and actually he was also randomized for a trial assessing what to do in these patients with atrial fibrillation and ICH. What about the radiological investigation? We do have an expert consensus statement also on the use of additional imaging, either CT or MR, to assess and to select patients for angiography, and also an evidence-based recommendation, although weak and based on low quality evidence, to use algorithms to also to support the decisions, such as diagram for the target investigation of ICH. The next topic is outcomes and withdrawal, specifically withdrawal of treatment. So we know that this is a question often in severe patients. Limitation of treatment was the question. Do not attempt DNR orders or early initiation of palliative care orders within the first 24 hours compared with standard care, whether this would influence death or dependency. We don't have enough evidence to provide an evidence-based recommendation, but it is important to consider this expert and full consensus statement on the suggestion not to implement this general policy of limiting treatment or do not initiate cardiopulmonary resuscitation orders in these patients in the first 24 hours. This is based on mostly observational evidence, of course, but we can remember, for example, this landmark study from the UK on the care bundle. And indeed, there's this mediation analysis. We can see there was an important reduction in case fatality with the implementation of the care bundle. And this mediation analysis shows that this reduction in early DNR orders was associated with probably half of this reduction in the 30 days case fatality. So this it is an important thing to remember that we should avoid this early nihilism and this risk of the self-fulfilling prophecy by reducing treatment in patients that have a more severe prognosis. Also provide comprehensive acute care in the first 24 hours, one of the very few strong recommendations we can have in this guideline, and then do the investigation for the underlying cause and allow time for accurate prognostication before making treatment limitation decisions. Thank you very much, and happy to take a short question.
Thank you very much, Diana. That's very clear. And we don't have any time for questions, and there are none yet submitted. But to our many people who kindly joined us this evening, please pop any questions you have in the Q&A, and we will come to them later. So we will move swiftly on to Trina Apostolaki-Hansen, who's kindly going to tackle blood pressure management. Over to you, Trina.
Hi, everybody, and thank you, Rustin, for that introduction. So I'm going to be covering blood pressure, like you said, and it's a very large, there's a lot of material, so we're going to go through everything and just jump right into it. So the clinical question for PICO-2 is whether actively lowering blood pressure to a lower target compared to with either no specific target or higher target reduces death dependency or hematoma expansion. So the evidence-based recommendation states that for adults with acute spontaneous ICH and a systolic blood pressure between 150 to 220 mmHg, that the guideline concludes that the overall balance of benefits and harms is uncertain, and therefore the formal evidence-based recommendation is to prioritize recruitment into ongoing RCTs. And the quality of evidence is graded as low and the strength of recommendation is neutral. And this reflects persistent uncertainty despite multiple trials. So the panel provided expert consensus to guide practice where areas were uncertain. So for minor or moderate ICH with a hematoma volume less than 30, we suggest reducing systolic blood pressure below 140 mmHg within the first 6 hours in order to avoid and reduce hematoma expansion. And we suggest avoiding a drop of more than 70 mmHg from baseline as was proposed in a sub-analysis of the ATTACK-2 and INTERACT trial, and to also avoid active lowering below 110 mmHg in order to avoid neurological deterioration and then potentially renal adverse events if you go even lower. So caution is also advised in very high BPs readings of over 220 and large hematoma volumes over 30 mils because of fear of high intracranial pressure and reduced CPP. And also there's very limited evidence around surgical evacuation and blood pressure lowering. So we also avoid caution there. So we recommend to initiate antihypertensive treatment early, possibly within 2 hours of symptom onset, because we know that hematoma expansion occurs within the first 3-4 hours, and to lower systolic blood pressure to 140 and minimize blood pressure variability, and to maintain the 140 limit for up to 7 days. So for the PICO-2, we screened 1,976 studies and came out with 14 studies that were included in the review. And then there was an updated review after the publication of the ESO guideline that included 2 additional studies, one by Dong et al. And another one, ICH-DAP2. So the grade evidence profile is presented here. And across outcomes, the certainty of evidence is generally low. And the reason for the downgrading is high risk of bias, heterogeneity between studies, and a limited number of events. And this explains why the recommendation is quite cautious. So now we're going to go through a bunch of forest plots explaining the data. And so when pooling trials together, we did not find any statistical significance in improvement of good functional outcome defined as MRS 0 to 2 at 3 to 6 months. However, the point estimates lean in favor of blood pressure lowering, but it is not statistically significant. But given the wide confidence interval and very low certainty of evidence, it must be interpreted with caution because the pooled estimate might be anchored by these early smaller studies as opposed to the with extreme effects and may not really reflect the results from the larger trials. So if we go on to the next, we also stratify the analysis by time from symptom onset to randomization and attaining targets. So within 6 hours, you could see that was a favorable signal in patients that were treated earlier for an improved functional outcome, but it was not as definitive at the other endpoints. They were mainly neutral. So this just suggests that timing matters and that BP control is probably most beneficial in the early time window. So time is brain. On this slide, we can see that we also stratified according to follow-up time. So 3 months was the majority of the trials had a 3-month follow-up presented in the trial, and there was only one with a 6-month follow-up, the SCAST trial, but they looked at per-os candesartan at 30 hours after stroke onset and followed them up to 6 months and retained that treatment for 6 months. So it's also a type difference in timing of the intervention, but also differences in the actual intervention type. So here we can see it's an updated version of the guideline where the Dong trial and is also included. And here we stratified the analysis by type of intervention. So we looked at BP target-based interventions where the intervention was primarily guided by a specific target and specific fixed antihypertensive agents. And these were mainly in the ENOS and the right trial, it was nitric oxide, and in the Dong, it was anesthetic drugs, and the SCAST was per-os candesartan. So for BP target-based interventions, we could see that there was a significant association with a higher probability of good functional outcome at 3 months compared as opposed to the fixed antihypertensive agent. And this probably doesn't reflect like flexibility in what drugs that you can use, but it probably means that like the fixed antihypertensive agents that we're looking at the wrong agents there. So for the next one, we'll go over to death within 3 to 6 months. And overall, intensive blood pressure lowering didn't significantly reduce mortality at 3 to 6 months. And most trials showed very similar neutral estimates for mortality. Here you can see in the forest plot. But this shouldn't be taken as definitive evidence, as it may reflect that these studies were underpowered to detect a modest but clinically relevant reduction in death. So for the next slide, on this slide, the trials were grouped for length to follow-up as well, and here we couldn't really see a clear mortality benefit in 3 and 6 month follow-up, but this is a little bit misleading because it shows in very many ICH or many studies have actually shown that ICH patients can improve all the way up to a year and switch from a dependent to an independent category throughout that time window. So a lot of trials are leading on for doing a 6 month follow-up instead. Here we can also see that deaths within 3 to 6 months stratified by enrollment time. So within 6 hours, 24 hours, and 72 hours of enrollment, we could see that death didn't differ according to symptom onset to treatment time. I'm aware that this is very statistically heavy, but it's very hard to go through all this without showing the forest plots. So here's death within 3 to 6 months stratified by intervention type. And here we can see that the BP target-based interventions were leading towards have a strong trend towards a reduced death with lower blood pressure targets as opposed to the fixed target group, similar to the functional outcome. And here, the last outcome that we look at was hematoma expansion after acute blood pressure lowering. And this study presents all the meta-analysis that included this outcome. It was definitely not all of the studies that reported this. And the point estimates favor blood pressure lowering, suggesting that less hematoma expansion occurs with active BP lowering in the acute phase. It's a strong trend, but it's not definitive evidence. And here we can see stratified hematoma expansion stratified by enrollment time. So within the 6 hour time window, we can see that there's a statistically significant reduction in hematoma expansion with lower blood pressure targets, and that the later treatment times showed a weaker, more uncertain effect, also supporting the notion that time is brain. And here we can see the blood pressure target groups versus or not versus, but also showing the fixed antihypertensive agent categories. And we can see similar results here favoring a strong trend for blood pressure lowering on decreased hematoma expansion. So to summarize, I probably have gone over my time. The expert consensus suggests 140 limit, so below that within 6 hours, preferentially commencing blood pressure lowering within 2 hours in mild and moderate, and to be cautious with the larger hematoma volumes and patients with very high blood pressure, and to also maintain this value for 7 days and reduce blood pressure variability. And you could do this by using fast-acting drugs and drugs that are easily titratable preferentially. So the overall pooled effects for a good functional outcome and death mainly show no clear results. Hematoma expansion has a much more stronger trend towards less hematoma expansion, and this is specifically when stratifying the analysis for time. That the earlier the blood pressure lowering, the less the hematoma expansion may occur, and we would hopefully like to push this even earlier, as we know that hematoma expansion occurs much earlier than 6 hours. And then there's also a possible trend toward better functional outcome and mortality in the stratified analysis. So in summary here, the certainty of evidence is low, and there's a substantial uncertainty about net clinical benefit. And there was also substantial clinical and methodological heterogeneity across the included trials, like the intervention protocols, for example, different drugs that were used, different thresholds, different patient characteristics, timing of interventions, and the outcomes. So a lot of these were not primarily powered to detect differences in mortality and functional outcomes. So there were very heterogeneous studies that were clumped together, and the larger trials maybe were subject to this small studies effect, which anchored pooled estimates and limited the influence of the bigger trials. So in summary, we know that more RCTs are needed to be able to answer this very important question, to see if there's a small effect of blood pressure lowering for these patients.
Thank you very much, Trina.
That is all I have today.
Thank you very much indeed. So that's a really clear summary of what we do know and what we don't know. One brief summary from me before we move to the next section. We've had a few questions come in the chat, and do keep submitting them, about the choice of drug to use, and also whether to use bolus treatment or continuous infusion, and also a question about how rapidly we should be reducing blood pressure within that 6-hour window. And what I just wanted to point out in the interests of time is that the guideline does say in the detailed text that the optimal choice of antihypertensive drug and the optimal duration of BP lowering are uncertain, but we think that the drugs that should be used should be fast-acting with a short half-life. There are many different antihypertensives that have been used in the trials, as people will know, and there have been no safety concerns about any of them, with the exception of venous vasodilators like nitrates. And we also identified that the calcium channel antagonist clofidipine appeared particularly attractive, but ongoing trials are going to address some of these things, as Trina says. So, Trina, thank you very much indeed for a thorough summary.
Thank you.
And I'm now going to hand over to Helle Eilertsen, who's going to talk about hemostatic therapy.
Thank you very much, and hello to everyone. So, hemostatic therapy aims to reduce the risk of hematoma expansion after acute ICH. And reducing hematoma expansion is important because it is found to be associated with a worse functional outcome and death. And the most feared risk of hemostatic treatment is the increased risk of thrombosis. So as a backdrop to this subject, I will present a short case of a 75-year-old woman with symptoms of acute right hemiparesis, which started 1.5 hours prior to admission at hospital. And for this section, the most important question is what is her current medication? Because what hemostatic treatment strategy is available depends on her use of antithrombotic treatment. So the ESO and EANS Guideline give recommendations on depending on whether the ICH is not associated with antithrombotic treatment, associated with antiplatelet treatment, or associated with anticoagulant treatment, respectively. And we will go through this in the following. And as you can see here on this busy slide, there's quite a lot of recommendations. For ICH not associated with antithrombotic drugs, the guideline gives recommendations regarding the use of recombinant factor 7A and tranexamic acid. So recombinant factor 7A stimulates the extrinsic pathway in the coagulation cascade, whereas tranexamic acid is a lysine analog which inhibit fibrinolysis through inhibition of plasminogen. So for the reuse of recombinant factor 7A, we found a total of 9 randomized controlled trials with approximately 1,500 participants, and both for the primary outcome of death or dependence at day 90 and for the outcome of thromboembolic adverse events, we found neutral results. And based on this, the evidence-based recommendation states that there is continuing uncertainty about the net effect and that it is suggested to continue recruitment in ongoing trials. For the use of tranexamic acid, we found 6 trials investigating the outcome of death or dependence at day 90 and thromboembolic adverse events. And the trials included a total of approximately 2,900 participants. And for both these outcomes, we found neutral results. So also for this, the evidence-based recommendation states that there is continuing uncertainty about the net clinical effect, and that it is recommended to include patients in ongoing trials. However, there is an additional expert consensus statement suggesting that tranexamic acid may be used to reduce hematoma expansion if no randomized trial is available. And that is based on this meta-analysis, where we found that hematoma expansion by 24 hours was reduced in the group who received tranexamic acid compared to the group who received placebo or were open control. So if our 75-year-old woman didn't use any antithrombotic treatment at the time of her ICH, the recommendation is that there is continuing uncertainty about the use of both recombinant factor 7A and tranexamic acid. It is recommended to enroll patients in ongoing trials. And if no trial is available, you can consider giving tranexamic acid to reduce hematoma expansion. Then let's move to ICH associated with antiplatelet use. Antiplatelets reduce the platelet function and thereby primary hemostasis. And the guidelines give recommendations on the use of platelet transfusion and desmopressin as hemostatic therapies. So platelet transfusion aims to replace some of the inactivated platelets, whereas desmopressin is a synthetic vasopressin analog, which enhances platelet adhesion and aggregation through the activation of releasing von Willebrand factor and factor 8 from endothelial cells. For platelet transfusion, we found 1 randomized controlled trial, the PAT trial, who found a primary outcome of death or dependence at day 90 in favor of placebo or open control. And for thromboembolic adverse events, there were neutral results. Based on this, the evidence-based recommendation is a weak recommendation against the use of platelet transfusion. For desmopressin, we found 1 small trial, the DASH trial, and for both of these outcomes, there were neutral results. Based on this, there is continuing uncertainty about the net effects of desmopressin, and we recommend inclusion in ongoing trials. So if the 75-year-old patient used an antiplatelet drug at the time of her ICH, the recommendation is to avoid platelet transfusion, but there is continuing uncertainty about the use of desmopressin. And then lastly, to ICH associated with anticoagulant use, and firstly to the use of vitamin K antagonists. So vitamin K antagonists affects the vitamin K dependent coagulation factors 2, 7, 9, and 10, which affects both the intrinsic, extrinsic, and common coagulation pathways. And there are primarily three reversal agents for vitamin K antagonists, which are prothrombin complex concentrate, PCC for short, fresh frozen plasma, FFP for short, and vitamin K. And vitamin K can normalize the coagulation factor levels in about 6 to 8 hours, but that is way too slow in the acute ICH setting. And FFP and PCC may normalize levels within minutes. So to the evidence of PCC versus FFP for vitamin K-associated ICH. For the clinical outcome of death or dependence at day 90, we found one trial with a neutral result. And based on that, the evidence-based recommendation is that there is continuing uncertainty about the effect on clinical outcomes. However, most of the randomized data on this is on biochemical outcomes, primarily the reversal or normalization of INR. And based on that data, there is an expert consensus statement suggesting to use vitamin 4-factor PCC together with vitamin K. And the dosage of PCC from 30 to 50 international units, the dose of 30 is the dose used in the EANS trial, whereas a dose of 50 international units per kilo is what is recommended by the manufacturer. And to prevent subsequent increase in INR, it is recommended to combine it with intravenous vitamin K. Then to factor 10A inhibitor-associated ICH. And factor 10A inhibitors does, as the name say, inhibit factor 10A. And there has been developed one antidote for this called andexanet alpha, which is a synthetic recombinant factor 10A, which reduce the effect of the factor 10A inhibitor. And for this, the subject of factor 10A inhibitors, we will also look at the use of PCC and tranexamic acid. So firstly then to andexanet alpha for ICH associated with factor 10A inhibitors, we found one randomized controlled trial with a total of about 500 participants. And the primary outcome of that trial was not the clinical outcome. But for the thromboembolic adverse events, it found a result in favor of usual care. And based on that, the evidence-based recommendation states that there is continuing uncertainty about the net clinical benefit of the use of andexanet alpha, and we can give no clear recommendation, and it is recommended to continue recruitment in ongoing trials. However, there is an additional expert consensus statement suggesting that andexanet alpha may be used within 15 hours after the last dose of the factor 10A inhibitor and within 12 hours since symptom onset to reduce hematoma expansion. And the expert consensus statement is based on this finding of the ANNEXA-I trial, which found that hematoma expansion by 24 hours was reduced in the group who got andexanet alpha compared to the usual care group. And the time limit in the expert consensus statement of 15 hours after intake is due to that being in the eligibility criteria in the ANNEXA-I trial, whereas the symptom time limit of 12 hours is due to that being the time of measurement of the primary outcome in the ANNEXA-I trial. Then for PCC in factor 10A associated ICH, we found no randomized controlled trial for this, and there is continuing uncertainty, and we can give no clear recommendation. But there is an expert consensus statement suggesting to consider giving PCC, but that this has to be considered for each patient individually because it is of unknown benefit, and it may increase thromboembolic events. And for tranexamic acid in factor 10A inhibitor-associated ICH, we found one small randomized controlled trial with neutral results, and we can give no clear recommendation, but recommend to recruit in ongoing trials. Lastly, in this subject, two factor 2A inhibitors, which is also called direct thrombin inhibitors, and they do exactly that, they inhibit thrombin. And there has been developed one antidote, idarucizumab. Idarucizumab is a monoclonal antibody which binds to the factor 2A inhibitor and neutralizes the effect of that when given intravenously. So for idarucizumab, there are no randomized controlled trials, and we can give no clear recommendation. However, based on observational data, there is an expert consensus statement suggesting to use idarucizumab to normalize clotting time. So, if our 75-year-old woman used an anticoagulant drug at the time of her ICH, there are no clear evidence-based recommendations due to lack of data, but 3 expert consensus statements suggesting to use prothrombin complex concentrate together with vitamin K in vitamin K associated ICH to normalize INR levels, to consider giving andexanet alpha in factor 10A inhibitor associated ICH to reduce hematoma expansion, and to use idarucizumab in factor 2A inhibitor associated ICH to normalize clotting times. So, to conclude, I think the main conclusion is that for all of these recommendations and all of these hemostatic treatment strategies, there are a lack of randomized data and lack of knowledge. So it is important to enroll patients in trials so that we can increase our knowledge and thereby better patient care. But for what we know for now, for ICH not associated with antithrombotic treatment, there is continuing uncertainty about the use of both recombinant factor 7A and tranexamic acid. We recommend to include patients in randomized controlled trials, and if no trial is available on tranexamic acid, tranexamic acid may be considered given. For ICH associated with antiplatelet treatment, the recommendation is to avoid platelet transfusion, and there is continuing uncertainty about the use of desmopressin. And for ICH associated with anticoagulant treatment, there are no clear evidence-based recommendation, but a recommendation to use PCC in combination with vitamin K in vitamin K antagonist associated ICH to normalize clotting times, to normalize the INR level, to consider andexanet alpha in factor 10A inhibitor associated ICH to reduce hematoma expansion, and to use idarucizumab in factor 2A inhibitor associated ICH to normalize clotting times. Thank you.
Thank you very much, Helle. Nice talk. We have time for a question. The one question is, andexanet withdrawn from the market in the US. Does this warrant a specific comment? Would you like to say something about that?
I think for what we know by now, there are no new data that's behind that decision. And we have heard nothing from the EMA. So, yeah.
Yeah. And one other question is, what about prothrombin complex in patients with ICH and no drugs, but radiological signs of expansion are there? Would you recommend giving PCC anyhow?
What was the question? PCC in?
What about PCC in patients with ICH and no drug, but radiological signs of expansion?
So PCC without any antithrombotic treatment?
Yes, I think the question means what do you do with PCC if there is no alternative? Do you give it or not? Which is a difficult question, but...
It is. And it's often easier, you feel the urge to do something, but I think there are no evidence for that. I would not give that.
Yeah, I agree with that. Yes. Okay, many thanks. This leads over to the fourth PICO question on neurosurgical interventions in patients with acute ICH to Floris and Jürgen.
Thank you, Thorsten. And on behalf of my colleague, Professor Jürgen Beck, neurosurgeon at the University of Freiburg in Germany, I would like to welcome you to the fourth PICO on surgical management in ICH. My name is Floris Schreuder, and I work as a vascular neurologist at the Radboud University Medical Center in Nijmegen, the Netherlands. So again, I would like to introduce this clinical case. It's a 63-year-old female with a history of hypertension, and she presents at the emergency department because of acute onset of headache and a left-sided hemiparesis that started 3.5 hours before. And she has, upon arrival at the hospital, a Glasgow Coma score of 365, a dysarthria, a left-sided visual neglect, and an MRC grade 4 paresis of her left arm and leg, resulting in a total score of the NAHSS of 8. And as you can appreciate, her CT scan shows a right parietal hemorrhage of 36 milliliters. And the question standing, and that we will be addressing in this PICO, is whether or not to perform surgery in this patient. So our PICO was subdivided in 3 questions, and on the left side you can see that we will first discuss surgical management and give recommendations on patients who have a supratentorial ICH. Next we will discuss treatment options for intraventricular extension of patients who have an intracerebral hemorrhage, depicted in the middle. And lastly, on the right side, you can see that we also discuss recommendations for patients who have an intratentorial hemorrhage. And just looking into the guidelines of 2014, so the previous version of the ESO guideline, you can appreciate that the recommendations on surgical management were quite sparse and quite weak. So no clear recommendations could be given on any type of surgery, mostly due to evidence not giving a clear indication of benefit or due to the lack of randomized clinical trials providing data. And our first PICO question asked whether in patients with acute supratentorial ICH, does any type of surgery aimed at clot removal reduce the risk of the death and dependence when compared to no surgery? And please remember that in the 2013 guideline, there was stated that there was no evidence to support surgical management except perhaps in some selected patients. And this is the recommendation in the updated guideline. And we suggest surgery aimed at hematoma removal to reduce the risk of death and dependence. And we stress, however, to take into account additional factors such as the hematoma location, hematoma volume, patient's neurological condition, timing, method of the intervention, and the known complication rates. And we will come back to this at a later point. Please also, because of the different types of surgical interventions, we have 3 additional PICOs which will address all these types of surgery. So in the next few PICOs, we will address first craniotomy, then minimally invasive surgery to remove the hematoma, and lastly, surgery with catheter placement plus thrombolysis. But first I will show you the forest plots of the studies that we found after our search of the literature. And these are a total of 17 trials completing nearly 4,000 participants who underwent any type of surgery aimed at clot removal. And on the left, you can see the plot for death at 3 to 12 months. And we found an odds ratio of 0.75 with a small confidence interval indicating that there's a 25% reduction in death with surgical management compared to no surgical treatment. And on the right, you can see the forest plot of good functional outcome, again, between 3 and 12 months, and good functional outcome was defined as a modified ranking score between 0 and 3. And surgery also resulted in an improved odds of good functional outcome with an odds ratio of 1.68. And I'll now give the word to Jürgen, who will address the different types of surgery next.
Thank you, Floris. And thank you for the big advancement that we now have a recommendation, a suggestion to proceed with surgery for ICH, which is a step forward from the last guidelines. But as you mentioned, the trials have been quite heterogeneous, and we asked 3 more questions to subdivide and to stratify what type of surgery into whether craniotomy or stereotactic aspiration with catheter placement and clot lysis or minimal invasive surgery is beneficial for our patients. Coming to the first question, we asked ourselves whether conventional craniotomy by open means and standard surgical technique and clot removal is of a benefit for our patients. And as you can see now, we have an odds of that is including the one for death. So we are not sure that it reduces mortality, and the same goes for good functional outcome. Despite being a signal there, it missed statistical significance. And so the recommendation is that we do suggest consideration of early surgical hematoma removal by means of open standard craniotomy and standard surgical evacuation in non-comatose adult patients. The quality of evidence is very low and the strength is weak. Coming to the next question. So whether now minimal invasive surgery, the technical advancement of minimal invasive surgery is getting a different result, and you can now see that we still have low evidence, not very low evidence, but low evidence, and we now have an effect on mortality, reduced mortality, as well as on better functional outcome at 3 to 6 months, and the odds is not including the one anymore. So the suggestion now here is to proceed with minimal invasive evacuation of the hematoma within 24 hours early. And now we have another caveat, which, because the effect of this study is mainly driven by the landmark trial ENRICH, which was enriched for lower hematomas. So the effect is not certain, or it remains uncertain in deep hematomas. So we still encourage to recruit patients in currently ongoing randomized trials. What about very minimally invasive therapy, meaning catheter placement plus thrombolysis? Whether this is better than best medical therapy for risk of death or dependence. And here the results are neutral. So currently this is mainly driven by the very elegant MISTI trial, but the results are neutral. So currently we do, there's still uncertainty about the surgery with catheter placement plus thrombolysis is beneficial for reducing mortality and improving functional outcome. So there is a very low quality of evidence and no recommendation, but instead of, as always, we do recommend when we have no evidence to recruit to ongoing randomized trials. There is a new event that we can do decompressive surgery for the most severely affected patients with large, deep ICH. And there is weak evidence for a benefit of decompressive craniectomy without touching the hematoma. But again, the evidence is weak and the odds is including the one barely, but it is. And so we suggest consideration of decompressive surgery without hematoma removal for reduction of death and improvement of dependency. But please, there's also a caveat here. Bear in mind that good functional outcome is defined here as a modified ranking scale of 0 to 4, as opposed to the modified ranking scale of 0 to 3 in all other surgical trials, meaning that even there might be weak evidence for a benefit, survivors are probably still severely handicapped. And this leaves us that this always should be and will be currently individualized decision-making, and in the best circumstances by shared decision-making with the caregivers. So for the surgical trials, this was the evidence, and I'll hand over back to Floris, please.
Thank you, Jürgen. I will move on to the second part of our 3 main topics. So looking into the intraventricular hemorrhage of patients who have intracerebral hemorrhage. And the first PICO that we want to address is the examination of use of extraventricular drainage with or without combined lumbar drainage to reduce the risk of death and dependency, but also the risk of future shunt dependence. And as you can see on this slide, unfortunately, there was no randomized clinical trial data available. So we suggest that this uncertainty is reflected in our evidence-based guideline recommendations, but we stress the importance of recruiting patients into novel randomized trials. And based on the expert consensus, we suggest to treat these patients with intraventricular extension and a hydrocephalus, who also have an impaired level of consciousness, to treat those patients with extraventricular drainage to reduce the risk of mortality. So the second question that we have aiming at intraventricular extension of ICH is the question whether or not extraventricular drainage with intraventricular thrombolysis versus extraventricular drainage without intraventricular thrombolysis reduces the risk of death, dependency, or shunt dependence. And we suggest to consider this treatment to reduce the risk of death, while the effect of this treatment on dependence and also dependence on the shunt is yet unclear. And we base that on this overview, which is the forest plots of 3 smaller and 1 larger trial, being the CLEAR trial, with a total of close to 600 patients, and the odds of death was reduced with more than 50%, and being not including the one, so being a significant effect, whereas there was no significant effect on good functional outcome or shunt dependence. And the third topic of intraventricular extension of the intracerebral hemorrhage is whether or not to perform surgical removal of the intraventricular blood and compare it with standard treatments, and examine the effect on the risk of death, dependence, and shunt dependence again. And based on small randomized trials with a total of close to 300 participants, we suggest to perform minimally invasive removal of the intraventricular hemorrhage to improve functional outcome and reduce the risk of shunt dependence, which was based on this overview, these 3 forest plots, where the odds of death were reduced by the half, but just didn't reach statistical significance, whereas the odds ratio of good functional outcome at 6 months was evidently improved, as was the risk of shunt dependence. However, these were small trials, and we suggest that an adequately powered randomized clinical trial comparing endoscopic treatment with EVD versus EVD alone is still lacking and should be performed. So that about intraventricular hemorrhage. And lastly, we move on to intracerebral hemorrhage. So in patients, we specifically focus on a cerebellar hemorrhage. And unfortunately, again, there were no randomized clinical trials available to investigate the effect of surgical treatment in patients who have a cerebellar hemorrhage. However, there is an individual patient data meta-analysis of observational studies from which a propensity score cohort was performed, totaling of 300 participants. And in this cohort, the proportion of patients who underwent, who survived at 3 months was significantly increased among patients who underwent surgical hematoma evacuation, as can be seen from the forest plot. And this was mainly found in patients with a cerebellar hemorrhage larger than 15 milliliters, and therefore we suggest to perform surgical hematoma removal in patients with a cerebellar hemorrhage larger than 50 milliliters. Unfortunately, the effect on functional outcome was not significant. And with that, I'd like to give the word back to Jürgen.
Thank you, Floris. So you've seen that slide already, which is a tremendous advancement that now we have. If you combine everything, we do have some evidence that surgery aimed at clot removal is beneficial concerning mortality and good functional outcome. And this is Thorsten Steiner and our group now have taken additional features or factors into consideration, which is hematoma location, hematoma volume, the patient's neurological condition, timing of surgery, and the method of intervention. And we do not want to leave you alone with these features and factors. So we analyzed this in some more detail, and suggestions from the group and by analyzing the literature is that the results are probably mainly valid for lower hematomas, which is that there's a strong signal that lower hematomas do benefit from surgical removal. What is hematoma size? What is relevant? And around 20 to 100 cc seems to be the corridor for which surgery might be beneficial. The same goes for patient neurological condition as assessed with the Glasgow Coma Scale, meaning that deeply severe comatose patients shall not be operated on, neither shall we operate on fully awake patients. This leaves a corridor of a GCS for 8 to 13, or probably if you extend it to 6 to 14, but do not operate on severely, deeply comatose patients and fully awake patients. Early surgery is better. So what is early surgery? And analyzing the literature, we might give you a number. Early surgery, you should do it the sooner the better. And early is here currently probably 24 hours. So the surgery should be done in less than 24 hours. And of course, not of course, as analyzed by the evidence, is minimal invasive techniques should be preferred. However, what are minimal invasive techniques? This is what neurosurgeons do. This is a minimal invasive mindset. This currently does not apply to the type of endoscope or the size of the obturator, but rather following the guidelines that do not cross eloquent areas, do the craniotomy as minimal invasive as possible, and do gentle hemostasis, use chunks like neuronavigations and ultrasound and all the tools neurosurgeons have. And of course, since we have some evidence that surgery is beneficial, of course, the evidence is still weak. So please take part in trials and continue with designing new randomized trials. The consensus is that we should now suggest and consider surgically hematoma evacuation with minimal invasive mindset or technique, especially in lower hematomas. And you might consider decompressive surgery in very severe, large, deep ICH, again, keeping in mind that this should be an individualized and shared decision-making process. For intraventricular extension, EVD placement plus intraventricular thrombolysis, or even surgical or endoscopic hematoma removal of the intraventricular hematoma is suggested. And for intratentoral ICH, consider doing surgery in ICH, intratentoral ICH larger than 15 cc's. Despite this, some call it the dawn of a new era. We have some evidence now. Please be aware of that this very weak evidence, and there are many areas of future research concerning about finding the best techniques, refining minimal invasiveness, and we should clearly target and include trials with whether we know which is the end of treatment target. There is one small signal from the MISTI trials that 15 cc's or less should probably be the end of treatment target concerning the volume reduction of the hematoma. And of course, we need to further refine patient characteristics and as well as hematoma characteristics, further location, size, and probably currently the biggest issue is what is early, when to operate. And as I told you, currently 24 hours or less, but this needs to be refined, whether earlier surgery really leads to better results. So this was our summary. Thank you so much.
Thank you, Flores. Thank you, Jürgen. This was a great summary of a complex topic which changed from the last recommendation because we have more data. And we also have some questions. I think we have time to answer some of them. And I would like to hand over the first question to you. Are there any trials separating lobar and deep ICH?
Probably the most information concerning the difference from lower and deep ICH we get from the wonderful landmark trial ENRICH, was was designed with an adaptive trial design and was, after the first interim analysis, stopped for deep because the deep hematomas did not benefit from surgery, even not from this minimal invasive surgery, but the lower hematomas did benefit. So, and even the overall effect in the ENRICH trial was driven by lower hematoma. Summarizing this, we might have a very strong signal for going on with surgery for lower hematoma, and we still might need to do trials and include patients in trials, randomizing patients with deep hematomas.
Another question is, as we now also have for the general recommendation, the option to go for surgery, which is a little bit a shift, different from the previous recommendation. Is there any etiology aspect of it? There's one question about amyloid angiopathy. Do we have some etiologies which may also be used to decide? Flores.
Yeah, I can answer that. There's, of course, within the trials, no clear data yet. But if you look at observational data, colleagues from the center in Leiden with expertise on cerebral amyloid angiopathy have studied whether or not patients with CAA are at increased risk of having complications from surgery, and they didn't find any evidence in literature for that. So at this point, there's no clear reason to avoid if you have a patient known with cerebral amyloid angiopathy, especially, of course, if these are the patients who usually have a lobar hemorrhage.
Thank you. Jürgen, you nicely addressed that it's not the device, basically, and also minimal invasive surgery is a rather a concept and approach and not one, hardware system. And the question here is there any, size dependency on the decision to use minimal invasive techniques or open techniques? So in other words, the smaller the hematoma, the more likely the minimal invasive, or is it applies to all sizes?
This is an excellent question. We extensively discussed and analyzed the literature concerning that, and there is no strong signal for size of the hematoma. The strongest signal is location and not size. So location clearly favors lobar hematoma. And there's even no clear threshold for size of the devices. So it doesn't matter whether the obturator endoscope is 15 millimeter or 10 millimeter. Probably currently other factors like, as they did an enrich really early surgery and selecting the right patients that are not deeply comatose, not fully awake, is currently more important, but not meaning that we should not put effort on refining our techniques, getting better and less invasive with our neurosurgical techniques. Of course, we need to do that, but currently there is no strong signal for that.
Okay, so let's say this is maybe the final question, which would be, is there any role for lumbar drainage?
Who would like to answer? Were you asking, Andreas?
Well,
I believe
Yes.
yeah, maybe you,
Okay,
Flores, or
right.
Jürgen, whatever, whoever.
No strong signal, no strong signal. Concerning intraventricular hemorrhage, the strongest signal comes from a drainage, but supratentorial interventricles plus thrombolysis or even direct surgical evacuation.
Okay. Good. Thank you. Thanks a lot. This was a very nice summary of a complex topic. And I would like now to hand over to Jan Puroger, who is a neurologist from the University of Heidelberg, talking about preventions of complications.
Yeah, thank you very much. I hope everyone can hear me. And it's really amazing to see that almost 500 participants are still online at this time. So in the next couple of minutes, I would talk about the prevention of complication, the management of complication in the acute phase of an ICH. Not talking about longer term complications that we will address a little bit later in the PICO 6 session. So one of the really feared complications in ICH patients is deep venous thrombosis and pulmonary embolism, because we have almost all ICH patients are really bedridden patients, immobile patients. They come with a lot of cardiovascular comorbidities, and they are in a need for hemostasis. And you have heard that we sometimes also administer substances that can cause DVT or PE. So we asked, in one of our first PICOs in this section, we asked whether physical measures can prevent deep venous thrombosis or pulmonary embolism, to reduce thromboembolism, symptomatic pulmonary embolism, or death, compared with standard of care. And physical measures include some more active and less active measures. For example, these are the intermittent compression stock compressions you can see here in this image, which have been addressed in a couple of RCTs that have included not only ICH patients, but also patients with ischemic stroke. And the class 3 trial was one of the largest trials, also including more than 300 patients with ICH, which compared these pneumatic compression stockings with routine care and found a benefit in the prevention of deep venous thrombosis. No clear statistical benefit for the prevention of pulmonary embolism, but a strong trend. So I will show you on the next slide our recommendation. We can have come up with that in immobile adults with spontaneous ICH, we suggest for intermittent pneumatic compression stockings for 30 days or hospital discharge or independent ambulation if sooner to prevent proximal deep vein thrombosis, but we acknowledge that continued uncertainty exists whether intermittent pneumatic compressions reduces symptomatic pulmonary embolism and death. So we still have very low quality of evidence. I've told you that we have mixed studies, including ICH and ischemic stroke patients, but we still give a weak for intervention recommendation here. So what alternative would we have? In a lot of countries, short-term antithrombotic treatment is used. It's usually the subcutaneous low molecular weight heparins. And we went through the evidence we have. We found very few small RCTs that sometimes have not even the standards we would apply to an RCT nowadays. So at the end, to summarize, we have a very low evidence, quality of evidence, and we were not able to give evidence-based recommendation where we give an expert consensus statement that these low molecular weight heparins might be used for venous thrombosis prevention if intermittent pneumatic compression is not available or feasible. And this is very interesting. I started using these intermittent pneumatic compressions right after we have written this guideline. I was very skeptical about these intermittent pneumatic compressions before. I thought they are annoying the patients, leading to more delirium, but it's absolutely not the case. The patients are already well tolerating these intermittent pneumatic compressions and the nurses as well. So what about intracranial pressure management? I think there's a very wise question in the Q&A chat here regarding whether we shouldn't use CPP targets instead of blood pressure targets in ICH. And when I talk about measuring the intracranial pressure, that's really about what it is. It's not the intracranial pressure that is elevated. It's at the end, the reduced cerebral perfusion pressure that is relevant for the patient. But looking at the evidence we have for managing or for guiding our decision-making by continuous intracranial pressure monitoring versus no monitoring, to reduce at the end the risk of death or dependency, we only found one RCT course conducted in China, which had at the comparator conventional EVD leading for a CSF drainage. And this was a neutral to negative trial. So at the end, we were not able to give an evidence-based recommendation, but we give an expert consensus stage that at least in severe acute spontaneous space occupying ICH, if the clinical symptom monitoring alone is not feasible, the use of invasive intracranial pressure monitoring may be considered. So a large part of our PICO 5 session is also about the anti-inflammatory treatment. We were really surprised to see so many substances that have been investigated, particularly in ICH patients. Unfortunately, the majority really decided to take very short-term outcome parameters. And I think this is really contradicting the pathophysiological process in ICH, which usually, which as far as we know, is an anti-inflammatory process starting after some hours, but then continuing over days or over weeks. So I think this really has to be taken in mind for the design of future RCTs. And I won't go through all these RCT here for the matter of time, but you can see we have seen a lot of substances here where have only been one RCT or two RCTs been performed. There are a few exceptions, for example, the corticosteroids, where have been also one larger RCTs performed with the well-methodological standards. But at the end, particularly in corticosteroids, they were negative. So there were worse outcomes for the patients that had been treated with corticosteroids, and had been overall neutral outcomes in the other RCTs. So to summarize, we made a recommendation against the use of anti-inflammatory intervention, particularly of all these substances here, outside of future controlled trials. And something we all deal with when we treat with our ICH patients are seizures. And I think there are two different situations we have to address. One is just the primary prevention, that because we are afraid that the patient might get a seizure, and the other is that once a seizure has occurred, that we treat the patient to not get a second seizure, or more the secondary prevention part aspect. And there have been RCTs performed that have used the more modern substances, for example, levetiracetam. And it's interesting to see that these RCTs performed for primary prevention had been neutral, but also have not shown really a negative effect. So we came up with a weak recommendation against the use for primary prevention. But if you started with, you can use it for some days, of course, but then discontinue it. And for if it is initiated and if no further seizures occur, so we recommend as an expert consensus statement that these anti-seizure medications can be discontinued after 4 weeks onwards. So this is probably the phase after the inflammatory phase, for example, also comes to an end. And I've jumped over some other aspects we have addressed with our PICO5. That is, for example, the glucose management or temperature management, because they are also have been applied to in a combining approach that is a so-called care bundle, which is the approach to combine not only glucose and temperature management, but also other aspects that have been addressed in other PICOs, like the blood pressure management or the early conduction of a neurosurgeon to care bundle. And to summarize here, the evidence we have found, there has been a trial in a mixed population of acute ischemic stroke and ICH patients performed in 2011 that had used this care bundle approach already in 2011 with addressing fever, temperature, sugar, and dysphagia. And there's been the large INDEX-3 trial. It has been a cluster randomized trial that has really led us or guided our recommendation, which I will show in a few slides. But of course, this is a more Asian population. We can discuss a little later whether this is generalizable to the Western population and the INDEX-3. And there's been also some differences. For example, in INDEX-3, there were very, very few withdrawal of cares, much fewer than we would expect in our population here. And the Perry-Jones study have also been referred to by Diana before when she addressed the DNR orders, which was not part of the Perry-Jones study, but was a very nice or interesting side effect of the introduction of a care bundle in this quasi-randomized pre- and post-intervention study. So to summarize here, we have found some evidence that from the INTERACT-3 trial that applying a specific care bundle compared with the usual care can reduce worse functional outcome or leads to a better functional outcome. So the chance to getting a good functional outcome is better and can reduce the mortality. So this is why we give a weak recommendation for implementing a care bundle to reduce death or dependency. And I've not shown you data from prophylactic treatment, the previous trial that have used prophylactic use of temperature lowering measures, prokinetic, antiemetics, or antibiotics. But this trial has been negative, so we give a weak against intervention recommendation here. But I think more interesting for you than this evidence-based recommendations, what we have written in our expert consensus statement, which are more really on the daily clinical base usable targets you can use. For example, for treating elevated blood glucose, treating of pyrexia, the very fast reversal of abnormal coagulation, but I think very importantly also the additional components, for example, the avoiding of do not resuscitate orders within the first 24 hours, until there's a clear will of the patient, the routine application of the dysphagia screening and treatment, which is very important, And we've heard this before, the early consulting of a neurosurgeon to evaluate surgical measures in patients such with a large spontaneous ICH, intravertebral bleeding, or with these space-occupying interventricular hemorrhages. But of course, more randomized trials are needed. So this is just an AI-generated slide here summarizing what we have written in our guideline. So please refer to our guideline. And I'm happy to take some questions now.
Thank you very much indeed, Jan. So we have probably a minute for a question. I'll stick to venous thromboembolism prevention, since one of the things that you learn as a guideline co-author is that there's variation in practice, and it's nice to hear when your colleagues are converted to the evidence. So Jan, thank you for telling your personal story about intermittent pneumatic compression. There are a couple of questions about it. Firstly, about immobility. Somebody's wondering if the NIH stroke scale score should define that. And secondly, whether there's any particular type of intermittent pneumatic compression device that we are recommending.
So starting with the last part of the question, no, I'm not giving some particular recommendations here. I could tell what we use and what has been used in this Lancet trial. But you probably have even more experience with it, so maybe you can give one. But I think it should be one which is really easy to use, not loud, not producing any noise. I think these are the more important questions. And to come up with NHSS defining immobility, I think I would not use the NHSS to define whether a patient is mobile or not. I think I would use my personal experience as a physician or talk to our physiotherapists and see whether the patient is really is laid down bedridden, or if he can walk around the ward, and the time he's walking is more than the time he's still in the bed. So I think this is almost the decision, the tipping point, when we can then decide to avoid any type of anticoagulation or intermittent pneumatic compressions for prevention of DVTs.
Yes, exactly. If somebody's immobile, they can't walk, we probably don't need to score that. And in answer to the device question, well, in the CLOTS-3 trial, which was the one for all stroke that investigated this, it was a Covidian system, yes. So the Kendall Express Sequential Compression System, which was thigh length sleeve inflation system.
Yeah.
Okay, so at the moment, I think those are the major questions. That's the major question for you, Jan. So without further ado, thank you very much indeed for all your hard work in the guideline and for summing up that section so nicely. I'm now going to hand on to Jesper Petersen, who's going to sum up our recommendations about secondary prevention after intracerebral hemorrhage. Jesper, over to you.
Oh, thank you. Thank you very much. And I will have some short slides, probably fitting to the end of this excellent, fantastic session. Obviously the patient case here is a patient who has survived the first 7 days of care. We will jump right into it, please. The next slide. Yes, and blood pressure control. When we started this guideline, we thought that this was the obvious one, the easy one. Actually, surprisingly little evidence for secondary prevention by blood pressure control after an ICH. There is huge evidence for primary prevention. It's been known for decades or even longer. But here, the quality of the evidence was low, but still the strength of the recommendation is strong. So of course, we should apply blood pressure control to reduce the risk of stroke. We also have an expert recommendation because there is a lack of evidence on what drugs to choose. But we would suggest a strict target of 130/80 or less, using a combination of antihypertensive drugs. And this is based on post hoc analysis of trials the ERIC trial that has some years now and not that new, and the SPS3 trial, which actually showed that a target of 140 systolic was inferior to the target of 130. So these patients should really be treated according to guidelines, strong guidelines. Next slide, please. Now, an area which we knew would be controversial and difficult. Again, the quality of evidence is low. The strength of recommendation is neutral, and there is an uncertainty about the net benefit of long-term oral anticoagulation after in patients who have atrial fibrillation and who have survived their ICH. But also here we provide a consensus statement that direct-acting oral anticoagulant treatment after ICH seems to increase the risk of ICH, but reduce the risk for major cerebral adverse cardiovascular events, and that a DOAC treatment may be considered after careful individual risk evaluation. This is based on post hoc evaluation of the Apache, SOSTART, and Prestige trial. Mortality was actually neutral in that analysis, while there was it seemed that ICH in the long term, the risk for ICH would actually increase while the risk for MACE would decrease. And the ENRICH-AF trial, not to be confused with the other ENRICH trial, was actually stopped because of increasing long-term risk for ICH. We also provided some examples of criteria to consider in your patient if you have 10 or more cerebral microbleeds. This might be a patient where you should not consider oral anticoagulation. Also, a definite diagnosis of cerebral amyloid angiopathy, an uncontrolled hypertension, or a history or ongoing uncontrolled alcohol abuse. Those are patients where one should probably not use oral anticoagulation, even in the presence of atrial fibrillation. And we would suggest ongoing trials for these patients. Next slide, please. As to left atrial appendage occlusion for patients with atrial fibrillation and who have suffered an ICH, there is uncertainty, and enrollment in trial is recommended. We actually found lots of smaller uncontrolled trials, single center trials, observational trials, but it does not add up to a strong evidence in this area. The expert consensus is that it may be considered in patients who are unsuitable for long-term OAC, but we strongly recommend enrollment in RCTs. And if you would consider starting a patient or applying an appendage occlusion, you will need periprocedural antithrombotic treatment, and there we refer to the excellent European Society of Cardiology guidelines. Next slide, please. Now to antiplatelets after an ICH, what to do? Well, the evidence is moderate, the strength of recommendation is weak, but restarting antiplatelets, if you have a licensed indication, seems safe, but the overall effect of this is still uncertain. There is the RESTART trial, which did suggest that the ICH recurrence actually was lower in patients with antiplatelet treatment, but this was not significant. Also, the ischemic events were lower, again, not significant. and the effect on mortality was actually neutral, and there are ongoing trials in this area. The expert consensus again is that we strongly suggest enrollment in RCTs for these patients, and we did not recommend starting antiplatelets for when there is no licensed indication outside of trials. Okay, the next slide, please. So now we come to the final PICO here, and this was about statins. There is a big literature out there, and the evidence-based recommendation is still uncertainty regarding secondary prevention with a statin in patients who have suffered an ICH. The quality of the evidence is weak. The expert consensus statement, which is in part based on we identified 9 observational studies where we could do a small meta-analysis, and it is suggested that statin treatments in patients with a high cardiovascular risk after individual risk-benefit profile could be done. But again, the quality of the evidence is weak. I think everyone here is aware of the Sparkle, the original Sparkle trial, which did show a small but still a bit difficult to deal with effect with more actually increasing ICH in statin-treated patients. And we have looked through, I think, a very big number of observational trials, studies, and some of them seem to point in the direction that ICH could be a little bit more frequent if you use statins, but others actually show the opposite. And my co-chair for this PICO, David Seifke, and myself, I think we have one message to all of you. Please do not provide more single-center observational trials on statin treatment in these patients. So if you consider a trial, you should try to find a large multi-center randomized control trial. Thank you. That was my last slide.
Thank you very much, Jesper. I have one question I see in the chat. Do you have any thoughts on stopping statin in the first days of ICH?
I would say my personal view would be to stop it for the first week and then make this individual evaluation. That would be to make a very long story short.
Okay. Yeah. Rustam, would you like to comment on the session or on open questions? I see that we have worked on a lot of questions here already.
Yes, I think before I hand over to you to sum up, Torsten, the one major one is about intensity of blood pressure lowering for secondary prevention. I know, Jesper, that this isn't something that's been specifically addressed by the trials, although you may be aware of the Trident trial result that's going to be published soon. But I thought that was the one remaining question that you could quickly comment on.
Yeah, maybe you could do that yourself, Rustam, actually.
I think there are lots of observational studies, as you've referred to, Jesper, that in this instance show associations between lower achieved blood pressures and lower risk of stroke for secondary prevention. But of course, those are non-randomized, and maybe the people in whom it's easiest to lower blood pressure are the ones who are least likely to have major events in the future. But I think the Trident trial of the triple low-dose antihypertensive pill achieved a very significant further reduction in blood pressure, almost 10 millimeters of mercury systolic, over and above standard care and showed a substantial reduction in the risk of major adverse cardiovascular events, presented at the World Stroke Conference and soon to be published in New England Journal. So hopefully that convinces everybody that the lower, the better, provided it's tolerated.
And that would actually fit with the older trials. The signals we find there actually do fit with that. So that would actually be excellent to have this confirmatory trial. Yeah.
Great. Thank you very much, Jesper. And I'll hand over to Torsten, our chair, to wrap up.
Yeah, thank you, Rustam. And thanks to everybody. Thanks to all of you who have attended this guideline webinar. Next. If you have further questions, you can contact the corresponding authors. You'll find mails in the publication. If you want to check out next ESO guidelines, here are the QR codes you may want to scan. And next, I would like to thank all the people who had contributed to the ESO-EANS guidelines and made this webinar possible, particularly our speakers. So many thanks to you all. Next. I would also like to thank the ESO Guideline Board and the working groups. Being part of the ESO Guideline Group, I know that this is a hell of a work. And so my particular thanks are going to the chairs of the Guideline Board, Georgios Tsifkoulis and Diana de Sousa, Agriat de Sousa. Finally, I would like to thank Yvonne Brüchert, who is of very great help for all of us. Without Yvonne, I would not know how we could achieve all this. So thank you again. Finally, I'd like to thank Ken Lees and Else Charlotte Sunset at the European Stroke Journal editorial office for all their work they have done. So thank you very much. Thanks for attending. Thanks to my colleagues. Have a wonderful day. Bye-bye.